Great. And then I am very excited to introduce you. All right.
Okay.
So to have us here today, to speak to us today, we have Dr. Alexis Cutchins. She is an assistant professor of medicine in the Division of Cardiology. She's originally from New York City and graduated from Hamilton College in 1998, followed by receiving her MD degree from Emory University School of Medicine in 2004. She completed her residency in internal medicine at Weill Cornell in New York, followed by an NIH Cardiology Research Fellowship at UVA. And then we were lucky to have her come back and join us on faculty at Emory in 2012 with a specialized focus in cardiovascular disease in women. Dr. Cutchins is a member of the Emory Women's Heart Center and medical director of the Emory University Hospital Midtown Echo Lab. She has spent the last 12 years developing expertise in the area of postural orthostatic tachycardia syndrome, or POTS, and her research interests also include long COVID, venous disease, and mast cell activation syndrome. So super fortunate to have her educating us about this important disease today. The title of her talk will be The Role of Connective Tissue Disorders, Venous Disease, and Mast Cells in Postural Orthostatic Tachycardia Syndrome. And Alexis, I will hand the mic over to you.
Okay, Karen, thank you so much. I appreciate it. And thanks for having me. I appreciate the invitation. I'm happy to be here. And I'm just going to get started because there's a lot to go through. So I was asked, let's see. Oh, no, I have no financial disclosures. I will say that I see hundreds of patients with POTS, inappropriate sinus tachycardia, dysautonomia, if you want to call it. A lot of what I'm going to say is coming from personal observations and anecdotal perceptions of these patients that I've created over the years. There's a significant bias in the population of patients I see because many of these patients that come to see me have seen a lot of physicians before and have not gotten the treatment that they've been looking for, or they have been misdiagnosed as something else. And so I'm seeing people who have been really struggling with care for their disorder. And so there's definitely a skew in the population of patients that I see. So I just want everyone to be aware of that. I was told to give a little anecdote about myself. So I was born in New York City, as Karen said, but transplanted to Atlanta 12 years ago, and the mother of three amazing young women. So that's short and brief. I'm going to keep moving. I'm going to start off with a clinical case. This is a patient of mine, a 22-year-old woman with Tourette's and POTS. She came to see me because she was, having a lot of difficulty with her symptoms, and her review of symptoms was positive for seasonal allergies, bilateral leg pain, pelvic pain, pain with intercourse, joint hypermobility, and dysphagia. And you'll see why all of those are important, hopefully, by the end of this talk. Her heart rate in clinic was consistent with postural orthostatic tachycardia syndrome diagnosis, going up over 30 beats per minute from supine to standing. She had blood work that showed a low magnesium and a mildly elevated norepi level, which is consistent with a sort of hyperadrenergic state. Her lower extremity venous Doppler showed bilateral lower extremity reflux. She had a pelvic vein ultrasound with left iliac vein compression, or May-Thurner syndrome. She was intolerant to many medications, including SSRIs, beta blockers, midodrine, Florinef. These are all sort of first-line medications for POTS. And she had gotten to a point where she was just so depressed she couldn't care for herself or consistently take any medications whatsoever. This is just an image of her ultrasound of her iliac vein. You can see here the left common iliac vein is compressed by the right common iliac artery and the spine. On the right, you can see that image just in black and white, but it was very clearly demonstrated on the ultrasound. She then went on to have an IVUS of her iliac vein, which demonstrated compression of the left iliac vein at the site between the spine and the right common iliac artery. Distal to that, you could see that the left common iliac vein was dilated. So this is where it opened up and was no longer compressed. She ended up undergoing a venogram, and with dye injected, you can see here that the left common iliac vein is obstructed. This is by the right common iliac artery, and collateral veins have developed up the spine and across the pelvis. She had a stent placed to open up that left iliac vein, and afterwards you can see that the the cross pelvic collaterals and the paraspinous collaterals resolved completely. She felt great after this procedure. A couple months later, she sent us a message through my chart saying that her recovery went really well. She'd been playing pickleball. She'd become more active. Her appetite was back. She was able to eat more. Her mental health had improved. She'd been crying tears of happiness, and she had no more painful, heavy limbs, no more severe fatigue, dizziness, loss of vision, or other symptoms when she stood up, and she could jump up and run around and feel fine. She said she'd felt the best that she had in a long time. And this is a, dramatic case, but that's what we do, when we're presenting cases for what we're trying to discuss in these kinds of situations, right? So she did quite well with this procedure, and I want to just highlight sort of what I've been seeing in this patient population and why perhaps she did so well. So in overview, we're going to talk about POTS, the clinical features, and how to diagnose, and then 3 associated conditions: hypermobility spectrum disorders, venous disease, and mast cell activation syndrome. So POTS is a multifaceted illness. It is not just tachycardia with standing or dizziness and palpitations, but it encompasses many, many different organ systems and subspecialties. All of these relate to POTS, so autoimmunity, GI symptoms, cranial cervical instability, tethered cord, infection is a huge one, and many POTS patients developed their symptoms post-COVID, cognitive dysfunction and chronic fatigue. But all of these play an interplay with each other and with POTS. So it's very important to keep in mind that there are a lot of factors going in to the symptoms of these patients, but I'm going to focus on just a few today, which is going to be venous disease, mast cell activation syndrome, and connective tissue disorders or hypermobility spectrum disorders. I just want to highlight a review paper that was written by our very own residents, Rebecca Steinberg and Weston Dicken, who is now a cardiology fellow elsewhere, and myself, which is a generalized review of POTS and the associated conditions and management strategies, if anyone is interested in learning more. So POTS is the most prevalent form of orthostatic intolerance. It's estimated that 1 to 3 million Americans suffer, and now post-COVID, probably up to 13 million with some sort of dysautonomia in the country. It presents more in women than men at a relatively young age, and like I said, increased since the COVID pandemic. But what's the impact of POTS? So there was a paper that came out looking at quality of life in patients with POTS compared to other chronic illness. And this was 94 patients. They were given a quality of life survey, the SF-36, which you'll see pop up later. And they were severely impaired compared to controls in many different aspects of this survey: physical functioning, role functioning, bodily pain, general health, vitality, social functioning, all significantly impaired. And 25% of these patients were on disability. I like to show this graph because it demonstrates that, and hopefully, I don't know, on my screen, it's cut off by the video, but this is a comparison of healthy controls. Patients with POTS are in black, and then we've got COPD and CHF in the white and gray bars. And you can see that patients with POTS are severely disabled, but also they have consistently low levels of functioning compared to COPD and CHF patients across the board in all different realms. So this is a significant disabling illness that needs to be treated and cared for. So what happens normally when you stand up? I like this image from the Lancet Neurology. When you're in the supine position, 30% of our blood volume sits in the thorax. When you stand, 300 to 800 milliliters of blood gravitates into the abdomen and lower extremities, with 10 to 25% of that plasma volume shifting into interstitial tissues. This is important. This results in about a 10 to 15 beat per minute increase in heart rate and an increase in diastolic blood pressure, about 5 to 10 millimeters of mercury. That's a normal physiologic response just to standing. In POTS, we see a more dramatic response with more pooling and a higher heart rate. Clinical features of patients with POTS include dizziness, lightheadedness, weakness, blurred vision, brain fog, and fatigue, but also other systems are involved: migraine, anxiety, shortness of breath and chest pain, nausea, abdominal pain, bloating, reflux, dysphagia, pelvic pain, and heavy menstrual periods, as well as allergy and medication intolerances and hives. And I like to say that many of my POTS patients have sort of more than 3 drug allergies. It's usually a longer list, and that becomes clinically important later on. Symptoms can come on abruptly or can be gradual in nature. Most patients have an abrupt onset. If it's gradual in nature, usually patients have had symptoms since adolescence. The symptoms often start with a life stressor or infection. So COVID, EBV, Lyme, they can wax and wane or be very persistent, and can be aggravated by exercise, postprandial state, carbohydrate intake, menstrual cycles, heat, and environmental, like heat in the bath or the shower. To diagnose POTS, the first thing that I do is rule out any arrhythmias. We want to make sure these patients aren't having a malignant cardiac arrhythmia with Holter or vent monitors. I also have patients show me their Apple Watch data, which can be very helpful. I perform orthostatics either in the office or at home with a 10-minute NASA lean test or with a tilt table test. And what we're looking for is a rise in heart rate of greater than 30 beats per minute with change in position from lying to standing upright. There should not be any orthostatic drop in the blood pressure. And in my practice, we don't do a lot of other autonomic dysfunction testing just because I have no expertise in that. We're not doing a bunch of these other tests, sweat box and breathing tests and things like that. I do my best to evaluate patients for mast cell activation syndrome and venous disease, certainly at least with the screening questions during our initial visit. Many patients with POTS are thought to have a panic disorder, an anxiety, or somatization disorder. I find this incorrect. Usually it's due to the vague nature of their symptoms and systemic complaints. Recognizing the diagnosis of POTS validates patients' concerns and is the first step into taking care of these patients. This is just an image of the NASA lean, just describing what it entails. You can have a patient stand with their feet 6 inches away from the wall, leaning their shoulders against the wall, and take incremental measurements of blood pressure and heart rate over 10 minutes to see what the change was from lying and sitting. And this is an image just of a tilt table test to demonstrate that we usually have the patient at 0 degrees for 15 minutes to equilibrate, and then we will tilt them up to about 70 degrees to and keep them there until they start having symptoms. You can see here in D, the bottom corner, that in POTS patients, the red line indicates heart rate, and the solid red line indicates a heart rate while standing. And the heart rate will bump up quickly once tilted and stay up pretty persistently, and then come back down again when the patient is put back in the supine position. You can note that there's not really a change in blood pressure or systolic or diastolic blood pressure, as there are in some of these other forms of syncope. On my physical exam, I evaluate patients for hypermobility. I use the Baton score, also a family history and any personal history of hypermobile joints. Like I ask specifically, were you able to put your foot over your head as a child? The answer is often yes, but there are a lot of screening ways to look for hypermobility, like frequent joint dislocations, joint injuries, joint surgeries, etc. I also look for venous pooling on exam, edema, and elasticity and translucency of the skin, or abnormal stretch marks and abnormal adipose tissue distribution, or lipedema. I evaluate for flushing in the face, rash, and dermatographia. And here are just some examples of what those look like. On the top left, you can see a patient who's in a tilt table test standing with this deep reddish purplish coloration to the lower extremities. That indicates venous pooling. When she was lowered down to supine position, you can see that that pooling went away. Below that is just some of the maneuvers we use to look at the Baton score to diagnose hypermobility spectrum disorders. And then the upper right is a demonstration of dermatographism, where a light scratch will cause a raised wheal on the skin. In the bottom right-hand corner, you can see the different phases of lipedema, which is abnormal adipose tissue distribution and depositing in the lower extremities here. Lipedema is a form of connective tissue abnormality, and in my opinion, is sort of, it runs on the spectrum of hypermobility spectrum disorders, so it's something to keep in mind. You can tell specifically that in stage 3, there's preservation of fat deposition on the foot. So there's a clear, distinct pattern that is not, that's not usual in regular adipose tissue distribution. So what's hypermobile EDS? This is sort of a general bucket for anyone who has not received a genetic diagnosis of connective tissue disorder or hypermobility disorder, such as Marfan's or vascular EDS. It's diagnosed based on clinical presentation, physical exam, and family history. Other forms of connective tissue have been eliminated. And there's emerging data for a genetic marker, but we don't have, it's not validated yet. It's not vascular EDS. Patients with vascular EDS have known arterial complications, but it's thought to be a disorder of the connective tissue and collagen. So HEDS patients notoriously have venous access issues. Their skin is thin and stretchy, almost translucent. It accounts for 90% of the EDS population. So the rest are different types, 1, 2, 4, etc. And we think that there are some abnormalities of collagen involved. So what do we see in patients who have HEDS? This is just a handful of the pathology that's seen in this population of patients, but they have cranial cervical instability, Chiari malformations, tethered cord, scoliosis, slipped discs, and spine pathology, median arcuate ligament syndrome, nutcracker or left renal vein compression, May-Thurner or left iliac vein compression, and mast cell activation syndrome. So I'd like to bring your attention to this paper that was published on the mechanical properties of diseased veins, and just highlight some specific information that was stated in this paper, which is that the venous system houses 70% of a patient's blood volume. It regulates venous return to the heart and therefore cardiac output. So if the less venous return you have, the more blood you have in your venous system, the lower your cardiac output is going to be, the lower the stroke volume. Our veins rely on collagen and elastin for distensibility and elasticity, and veins have a higher collagen content than arteries. So you can imagine in a patient who has dysfunctional collagen that their veins are not going to be normal, and they may develop an increased propensity to pool, dilate, compress, etc. So I recreated this image that I showed earlier with a hypothetical further redistribution of fluid during venous disease with standing. And what you can see is even less venous return to the thorax, more abdominal and pelvic pooling, and more lower extremity pooling. And this is, hypothetical, but what I believe is contributing a lot to patients' symptoms of POTS. So let's go a little bit deeper into venous disease. There are several different types of venous pathology. Varicose veins is one, and those develop from lower extremity venous insufficiency. We also see iliac vein compression or May-Thurner syndrome and renal vein compression or nutcracker syndrome. What I've left off here is the skull base venous compression syndromes, which are also very relevant and can cause significant symptoms. I just don't have the capacity to include that in this talk. So symptoms of venous insufficiency are aching and heavy, cramping, uncomfortable legs, especially when standing, swollen feet and ankles, burning, throbbing, or tingling sensations in the legs, muscle cramps in the legs, particularly at night, dry and itchy skin over the affected vein, restless legs, leg ulcers, discoloration of the skin in dependent areas, and pain that worsens with standing and improves when lying flat or putting your legs up. Now, if I ask my patients about these symptoms, the majority of them will answer yes to at least one of those questions. The symptoms of pelvic venous disease are pelvic pain, pain with intercourse, low back pain, and most of it is positional. So if it's worsened with standing or sitting for a long period of time, and better when you go into the supine position. So just to explain May-Thurner syndrome, so you have a little bit of an idea of what we're talking about, that I've included this cartoon, which demonstrates compression of the left iliac vein here in blue between the right common iliac artery and the spine. When this is a normal anatomy for patients, but when you have connective tissue disorders, you have less connective tissue holding the artery away from the vein and holding that vein away from the spine, as well as a more compressible vein because of the collagen abnormalities. So we see this compression happen. And you can see on the right in the MRI that the left common iliac vein is denoted by the red arrow, and it's compressed between the right common iliac artery and the spine in this image. When we do a venogram, we can see that just like I showed in the beginning slide with our patient, you can see compression that comes across the left iliac vein here and also actually across the right iliac vein. I've drawn in what I would believe is the aorta and the right common iliac artery, so you can get an idea of how that compression is causing decreased contrast to flow back towards the heart. So this study actually was quite interesting. It was about 50 patients that were evaluated on autopsy specifically for iliac vein abnormalities. And 16 of those patients had May-Thurner pathology. And what I found fascinating is that those patients had scar tissue and webbing that formed in the vein at that site of compression. And you can see in this sort of the drawing to the right that this is the depiction of what's on the left, which is an opening of the left iliac vein. There's a lot of gunk in there, and it seems that the rubbing of the walls of the vein together can induce tissue formation. And you could imagine that in a hyperinflammatory state like COVID, for instance, that there could be even more inflammation and tissue organization at that site, which may make that vein even more compressed or more scarred down. Historically, the symptoms of pelvic venous disease, like I said before, are pelvic pain worse in the upright position, pain with intercourse, vulvar pain, dysuria or symptoms of interstitial cystitis, low back pain, hip pain, and then varicosities of the labia, vulva, upper thigh, and testicle. But a publication way back when in 1949 also reported tachycardia, palpitations, and severe fatigue in a population of patients with pelvic venous disease, which overlaps nicely, as you all know, with the population of patients I see with POTS. Okay, so moving on to mast cell activation syndrome, what is that? I know that that's a new one for people, and it's somewhat controversial. But in about 2009, there was some sort of increase in interest in mast cell activation syndrome and the span of disease that it actually covers. And so what we're talking about here is a hyperactive mast cell that activates without a known IgE-mediated trigger. The mast cells release histamine, tryptase, and other cytokines, and they're involved in normal bodily functions like wound healing and tissue repair, but they're everywhere in your body. So they line the areas of tissue that are sort of outside or interface with your environment. And so the lining of the lungs, the lining of the bronchus, your skin, the vessels, those all have your GI tract is covered with mast cells, and they have normal functions and then they have abnormal functions. So the overarching disease is mast cell activation disease, and it can be split into two scenarios: mast cell activation syndrome, which is the mast cells that degranulate at inappropriate times, and mastocytosis, which is an increased number of mast cells, an abnormal increase. It's a large spectrum of disease, and at the extreme, patients will develop anaphylaxis regularly. A lot of these patients can't even leave their homes because they react to sunlight with anaphylaxis, things like that. On the other end of the spectrum would be mild allergies, maybe some sniffles every once in a while, maybe a little bit of an adhesive sensitivity. But then in between, there's all kinds of stuff. You can get autonomic disturbances, GI symptoms, rashes, fatigue, food restrictions, medication intolerances, urinary tract issues, et cetera. The list goes on. So it's very, it affects all systems. Symptoms include episodic flushing, surges in heart rate, some with orthostatic hypertension, or new onset hypertension with flares and symptoms, diarrhea, and syncope. You can get a hyperadrenergic response to standing. You can have many different cutaneous manifestations as shown on this slide. And patients can have weird sensitivities like sensitivity to UV light, vibration, smells, chemicals, barometric pressure changes, and positional changes. So, it does sort of shed light on some of these patients that I know we've all seen who maybe have some weird complaints. I think that their complaints are valid and probably real, but we just need to learn a little bit more about why they're having them. And I think that the mast cell activation process is a component of why patients have some of these complaints that are a little bit off the mark. So common triggers are many different things, but pollution and pollen, weather changes, stress or pain can trigger mast cells. Exercise to certain extents can trigger the mast cells. Different foods, alcohol, drugs can all have mast cell triggers. And when the mast cells are triggered, they result in many different symptoms: chest pain, fainting, swelling, headache, lightheadedness, abdominal pain, rashes. You can see the list goes on and on. Cognitive dysfunction, brain fog. So it's a little bit of a mystery and a detective job as to figuring out what the triggers are for certain patients and how to avoid those triggers in order to avoid a lot of these symptoms. So how do we diagnose mast cell activation syndrome? There's two camps. There's a consensus 1 criteria camp and a consensus 2 criteria camp. And if you use consensus 1 criteria, you diagnose mast cell activation syndrome in less than 1% of the population. If you use consensus 2 criteria, you're diagnosing up to 17% of the population with mast cell activation syndrome on some spectrum. So the folks that developed consensus 2 criteria thought that the consensus 1 criteria were too strict and were limiting the diagnosis of these patients, and they felt that over-diagnosing vis-a-vis consensus 2 criteria was more beneficial to this population of patients and not harmful to them. So there were two sort of seminal papers that demonstrate the criteria for diagnosis of mast cell activation syndrome. And the person who really led this consensus 2 sort of charge is Lawrence Afrin. He's really studied a lot about mast cells, and he's learned a lot about these patients, and he is an expert in caring for them. And so there's, the diagnosis and the consensus is still evolving, but many people are realizing that mast cell activation syndrome is more ubiquitous than what we once thought it was. With the consensus 2 criteria, we use a lot of different mast cell markers. I'll go into that in a second. And I will just say that Lawrence Afrin wrote this book, Never Bet Against Occam, which I found fascinating to read personally, but it was written for patients, and it is about the spectrum of illness that you can see with mast cell activation syndrome. I highly recommend it. So here's just a comparison of what the difference between consensus 1 and consensus 2 criteria are. And in consensus 1, we're looking for symptoms and greater than 2 symptoms plus anaphylaxis and an elevated tryptase level during an attack. Also, we're looking for mast cell targeted treatment, which improves symptoms. As far as known, there's no data in the literature that says that there has to be an elevated tryptase level during an attack to diagnose a patient with mast cell activation syndrome. We don't really have a lot of data on that. And in this process, many allergists will only check the tryptase level once, and then they'll declare that the patient does not have mast cell activation syndrome and will send them back to the referring physician. In consensus 2 criteria, we look for 2 systems that have mast cell symptoms, plus at least 1 minor criteria, which can include any mast cell mediator increase, the fact that mast cell directed therapies help, and biopsy of mast cells or biopsy of tissue in the GI tract or bladder that demonstrates greater than 20 mast cells per high power field, which is considered abnormal. So what do we test for mediators of mast cells? These are different mediators that are secreted specifically by the mast cell. You can look at histamine levels, which is challenging because if the sample is not put on ice, the histamine can degrade. Tryptase levels, chromogranin A levels are useful. They can be falsely elevated in the setting of PPI use. I ask my patients to stop PPIs before I check this marker. Random and 24-hour urine markers, including N-methylhistamine, histamine, prostaglandin D2, and leukotrienes. For prostaglandin and leukotriene, we need to hold NSAIDs prior to sampling for those. And then heparin, which is a very sensitive and specific marker, but difficult to detect in most labs. So I just want to note that we use histamine receptor blockers on the regular. We treat acute, severe migraine in the ER with antihistamines, vertigo, nausea, car sickness and seasickness, insomnia, highs, angioedema, and anxiety, all with antihistamines. And so I think we're all sort of already aware that there is some process going on in the body that affects multiple organ systems that can be treated with fairly simple medications. So how does this all play together? We've talked about the prevalence and diagnosis of POTS, EDS, venous disease, and mast cell activation syndrome, and there's clearly symptom overlap. So why is that there? And I just want to point out in this slide that's on this, the picture on this slide, that demonstrates in purple a blood vessel, in orange is a nerve, and then the black dots are mast cells. And you can see the proximity between the vessel, the nerve, and the mast cell, and how that degranulation of that mast cell could closely affect those structures in our bodies. So Murat Fudim, who's at Duke, wrote this sort of review of in advances in heart failure about extracardiac abnormalities and preload reserve and what's the interplay. And he looked specifically at folks with heart failure, but also with autonomic dysfunction, liver disease, and venous obstructions. In this side, you can see that the percent volume of blood is clearly located mostly in the veins and the venules, and pressure, which is blood pressure, is mostly regulated by arteries. He looked at different types of exercise intolerance, heart failure all the way on the left, with a central vascular congestion, as you can see here, and then patients with POTS who have congestion in the lower half of their body and a lack of and essentially reduced preload reserve is how he describes it. And then finally, in this slide, he demonstrates that impaired venous return results in decreased cardiac output. And so the concept is that with an obstruction to venous return or increased venous pooling, you'd have less venous return to the heart and therefore less cardiac output, less stroke volume, and less cardiac output. In this paper, there was discussion of Ehlers-Danlos and the comorbidities of Ehlers-Danlos syndrome, and I specifically wanted to add this slide demonstrating the difference between a mast cell with normal collagen versus a mast cell with dysregulated and unstable vimentin in the cells. And you can see in C2, you have this sort of disarray that leads to dysregulation or weakness and sort of excessive degranulation of the mast cell, whereas in C1, there is a tightly woven normal structure to the cell, and that helps prevent excess degranulation. So this is one thought, that the mast cells are different in patients who have a defect in collagen versus those who don't. And then finally, there was a study done in 2021 to look at mast cell markers in patients with POTS. which did show an increase in these an elevation in these mast cell markers. Out of 69 patients, 29 of all of them had at least one positive biochemical marker, so 42%. But of those that had symptoms like migraine, allergy, rash, GI complaints, there was actually 44 patients, so 66% of those had laboratory and evidence of some sort of mast cell disorder, so to speak. So we call this the evil triad, which is mast cell dysfunction, dysregulation, POTS, and hypermobility spectrum disorders, or Ehlers-Danlos. And just, some data has suggested that mast cell activation syndrome is present in 20 to 33% of patients with POTS. This is likely an underestimation done by just chart review. 20% of patients with mast cell activation syndrome have Ehlers-Danlos. Also, I think an underestimation. I saw 12 patients with POTS yesterday, and every single one of them had hypermobile joints. So I think it's much more prevalent. It just hasn't been evaluated enough. And then up to 48% patients with hypermobility spectrum disorders have POTS or orthostatic intolerance. So there's clearly a lot of overlap between these disorders. And what I would like to add is the venous disease component, which clearly is involved. So just from a clinical standpoint, to summarize here before we get to the next part, when I'm seeing patients with POTS, I see patients with hypermobility all day. If you ask about it, if you look for it, you'll see it. All of these patients have some spectrum of symptoms consistent with mast cell activation syndrome. Many of them have adhesive intolerances and adhesive allergies, medication intolerances, but also some of the more specific stuff like dysphagia and flushing, rashes. They'll develop rashes in the office while I'm talking to them. All of them have orthostatic intolerance. That's why they're coming to see me. But 80% of the patients that we see in our clinic have venous disease, and I'm going to get to that next. So people started looking at this overlap, and this was a case series published by Pam Taub of 3 patients who had the overlap of May-Thurner syndrome, postural orthostatic tachycardia syndrome, and Ehlers-Danlos, and just looking at that relationship. And at a similar time, Dr. Smith, who's an interventional radiologist, was looking for iliac vein compression in patients with POTS. And he specifically looked at 191 patients with POTS. They all had a history of a CT of the abdomen and pelvis for some reason. And those CTs were reviewed by 2 or 3 independent radiologists. And those were compared to 25 age-matched controls of female kidney donors. And who were apparently asymptomatic, although who knows exactly how asymptomatic they were. We don't know what questions they were asked. But in this population, 69% of the patients with POTS had recognized iliac vein compression on their CT, while 40% of the healthy female controls had iliac vein compression. So there was definitely a skew in the POTS patients. He then went on with Dr. Rowe, who's at Johns Hopkins, to study pelvic congestion, study a group of patients in a pelvic congestion support group. So these are patients who've had a diagnosis of pelvic venous disease, and they asked them about other comorbid symptoms. And just to make it easier, I converted this into a graph, but compared to the general population in yellow, the patients with pelvic venous disease had considerably more symptoms of dizziness, syncope, and heart palpitations, chronic fatigue, irritable bowel symptoms, loose skin or double jointedness, frequent or painful urination, migraines, jaw problems, and excessive sweating. So they found that this population of just pelvic pain patients actually had a lot more going on than just the pelvic pain. So what do we do to treat these patients? I'm going to go to the iliac vein because that's sort of where the money is today, but there's a variety of things we can do, especially for lower extremity venous disease, that are pretty simple, but that will be, at another time. So you can stent iliac veins, and you can also do sclerotherapy or coiling of the pelvic veins that are dilated. And this is just a systemic review, a meta-analysis of 37 studies published in Circulation demonstrating the safety and efficacy of iliac vein stenting, which has been developed over the course of the last 10 to 20 years as safe. It's a low-risk procedure. The risks are migration and thrombus of the stent, which are low risk. The other issue may be a metal sensitivity or allergy, especially in this population with mast cell activation syndrome. There's back pain with the procedure that usually resolves after 2 weeks, can persist longer, and sometimes patients can get an inflammatory surge-like response after stent placement that also resolves. As I showed before, this is just an image of what it looks like after a stent is placed into that left iliac vein. There are other forms of management. There's a procedure that can be done that Brian Tuckey developed that's called a fascial counterstrain, which may relieve some compression or drain the lymphatic system, which I think is also pathological in these patients. And he has some success with this. He's been teaching others how to do it. It doesn't seem to be a permanent fix, but it does sort of provide relief from a lot of symptoms, pain, et cetera, in the moment, and maybe for a week or 2 weeks at a time. Another potential treatment for this population of patients is the medication sulodexide, which is only available in Europe, but promising. It's basically an oral heparin, but it also is a glycosaminoglycan that can help fix or repair the glycocalyx. It's been around since the 70s and it has a very low risk profile. It's not FDA approved here, but there are promising studies in venous disease on this drug, so we need to do some research on this medication. So what do we do about patients with orthostatic intolerance? Do we stent their iliac veins? How does that work? We have no data to show that there's any improvements or that there's an FDA approved indication to stent patients with pelvic venous disease, but it does seem favorable that restoring that venous return would help their symptoms. So there was a study that looked at patients with chronic pelvic pain whose pelvic venous disease was treated, and they noted that after treatment, symptoms of pain, interstitial cystitis, and orthostatic intolerance all improved. When they looked specifically at orthostatic hypotension questionnaires, the initial population of patients who came in with pelvic pain, about half of those scored abnormally on the orthostatic hypotension questionnaire, sort of consistent with a POTS picture. Half of those didn't. And after treatment, 3 to 6 months later, the questionnaire was retaken, and the majority of the patients had now fallen into the bucket of not a non-diagnostic survey result, which was pretty impressive. I've been collaborating with Brooke Spencer in Colorado. She's an interventional radiologist, and I'll just give you the highlights of a couple of the things that we've been working on. We have 2 papers that we're hoping to publish or submit for publication soon. The first is looking at prevalence of venous disease in our POTS clinic, and the other is outcomes of patients post-stenting after a year. And so we know that the estimated incidence of venous insufficiency in the general population is about 40%. It's similar in the iliac vein compression category. At autopsy, we see about 14 to 39% of all comers have iliac vein compression. What we found from 135 patients is that 79% of them had evidence of iliac vein compression on imaging and or venogram with IVUS. This included both patients who had met diagnostic criteria for POTS and patients who had what we call POTS-like illness or symptoms of POTS without meeting the diagnostic criteria. What I'll note is that those 2 populations of patients both had the same amount of pelvic venous disease. There was no difference between the 2. When we looked at symptoms in this population of patients, 73% of them had MCAS or suspected MCAS. 24% had a formal diagnosis of hypermobile Ehlers-Danlos syndrome, and 26% had PCOS. 53% said that their symptoms started after COVID or were exacerbated by COVID. And like I said, 63% of them had a formal POTS diagnosis. And there was an array of symptoms: tachycardia, dizziness, brain fog, headache, migraine, lower GI symptoms, upper GI symptoms, but also 72% of this population of patients had pelvic pain. So in the second paper, we were looking at outcomes after stenting 1 year out from repair of pelvic venous disease. And this was done by reviewing questionnaires of patients, the orthostatic hypotension questionnaire, looking at scores pre-procedure and then 3 months out and 12 months out. And you can see a significant reduction in symptoms of orthostatic intolerance in this population of almost 150 patients. They also had a drop in their pelvic pain symptoms, which was also significant, as should be expected. And when we asked them about global impression of change 1 year out from procedure, 109 patients reported results, and most of them had a positive impact from this procedure. Some other data that we're working on is a RAND 36 survey in our population of patients, looking at the same questions that were done in that initial study I showed you on POTS versus COPD and CHF. And what we found in this population of 40 patients, 6 months post-stent, is improvement in the baseline is dark blue, the 6-month post-stent is light blue, and you can see improvement across the board in different categories of the quality of life survey, which we're still working on, but is looking very promising. The other thing I'd like to note is that we're trying to collect Apple Watch or device data from these patients who have it. This one in particular is a 49-year-old woman with a history of ankylosing spondylitis, POTS, mast cell activation syndrome, and pelvic venous disease. And she was stented, and she's an avid tennis player. As you can see, she plays tennis for 2 hours a day. But before the stent, her heart rate would hover close to 175 while playing. And after the stent, this is 6 months later, she noticed a significant drop in her exercise heart rate. So up to, she was really not going over 150. So about a 20-point difference in beats per minute during exercise for this particular patient, just to give you some other parameters. I have slides on POTS management, but we're coming close to the end of the hour, Karen, and I don't know if you'd like to take questions instead, and maybe I can save that for another talk, or I can go through these slides really quickly, either way.
I think, Alexis, maybe you keep going.
Okay.
I would say for myself, I'd love to hear more about POTS management, but I also
Okay.
invite everyone in the Zoom stratosphere to drop your questions in the chat so we can manage them and get to them quickly. Yeah, thanks.
Okay, perfect. So this is a brief overview because I wanted to put this in because I thought people might want to hear sort of what I had to say about managing these patients. So it takes a multi-organ system approach. I really do look for fixable causes of symptoms, including anemia. I can't tell you the number of patients who come to see me for POTS and they just have a low hemoglobin. So iron deficiency, CSF leak is often a culprit and can mimic POTS symptoms. Venous disease, as we've described, mast cell activation syndrome. Fibromuscular dysplasia has a significant overlap with POTS symptoms, and if a patient is presenting hypertensive, that can be fixed with angiography and angioplasty. Median arcuate ligament syndrome is associated, and if repaired, can help POTS symptoms dramatically. Also cranial cervical insufficiency and tethered cord. So if there is something fixable, I try. Iron supplementation is useful, and also regulating heavy menstrual periods. Regulating periods themselves, because hormone fluctuations can make POTS symptoms much worse. Many patients describe their symptoms aggravated pre-period, and so I do my best to try to get work with the GYNs to eliminate periods if possible. You can do a patch if there's a CSF leak. There are options for fixing the venous system if that's something that they're having symptoms with. I also very much empirically treat mast cell symptoms with mast cell targeted therapies. I find using mast cell medications, which I'll go over in a minute, really does help these patients and helps their autonomic nervous system and their heart rate and blood pressure sort of tone down and neutralize. Treating pain is important. So treating migraines or joint pain or other manifestations of pain is helpful in terms of calming down that nervous system as well. And then working on diet, and I'm going to have a plug here for diet modification. Unfortunately, our country is sort of riddled with a lot of poisons, so to speak, that are harming us on a cellular level, and there's a lot of systemic inflammation coming from these things. Roundup, sugar, seed oils, or industrially created oils, and all of those wreak havoc on the inflammatory system and can cause a lot of symptoms in these patients. So I very much recommend a clean sort of whole food diet, the use of relaxation techniques and meditation to help with sleep and stress. And I often recommend my patients to listen to Dr. Sorescu's patient-targeted YouTube videos, which he has 3 of, Sorescu to the Rescue 2.0. They're highly educational and useful for patients to see. I also sort of try to inflict the practice that, we need to be shifting the way we're living from, this high stress, high work environment to a more relaxed environment and wholer diet, so to speak. But that's not an official POTS treatment. But I will say there is not an official POTS treatment. There are no guidelines to treat patients with POTS, and there are no FDA-approved medications for patients with POTS. There are few randomized studies with very limited numbers of patients. And for the most part, I think there's a consensus agreement that exercise probably is the best thing for these patients. However, these patients are so debilitated and they have so much post-exertional malaise, and their symptoms are triggered often by exercise, that we really have to be careful and mindful on how we initiate exercise and who we initiate it in. So non-pharmacologic treatment of POTS includes volume expansion, greater than 64 ounces of water a day, electrolyte replacement, and increased salt intake. We use saline infusion as a last resort if patients really, a lot of patients have gastroparesis and they can't take PO and they really can't hydrate appropriately. In that case, I will use IV fluids, or in times of flare, if patients have infection or other illness going on, they'll need more intravascular volume. Iron, as I'd said before, compression in the form of socks, tights, or pneumatic compression, which I recommend often. This can be done at home, 30 to 60 minutes at the end of the day, and it redistributes fluid from the interstitial tissues back into the vascular space. And doing it I think consistently helps decrease that potential space for fluid to ooze into. Alpha lipoic acid is a supplement that's been looked at in some trials for orthostatic hypotension and helps bring blood pressure up. Vitamin D and vitamin C are both mast cell stabilizers, and vagal nerve stimulation, which has some decent data. As far as medications are concerned, I use an array of medications. None of these have large randomized controlled trials. Some of them have small studies on 20 patients or 40 patients. Fludrocortisone expands the blood volume. Midodrine helps increase blood pressure by tightening up the arterial system. Ivabradine slows the heart rate without dropping blood pressure, which can be helpful. Beta blockers and calcium channel blockers will lower the heart rate, which is also helpful. And calcium channel blockers can help with chest pain or vasospasm, which is often an overlap in these patients as well. SSRIs have been looked at. I use them to augment venous return and not necessarily for depression and anxiety. And I tell patients that because they're very hesitant to go on any kind of psychiatric medications because they don't want their illness to be thought of as a psychiatric condition. Pyridostigmine has been looked at and helpful. Desmopressin, clonidine, and droxidopa. All of those work in different ways. And it's a lot of trial and error. Sometimes patients will have to try 1 or 2 or 3 meds before we find one that's really working well, or we have to use a combination to get patients to a point, in my opinion, where they can start exercising. And that's the key, to get them exercising as much as they can. Oral contraception, like I commented on before, or IUD placement, progesterone only treatments like Nexplanon or Depo-Provera really help to eliminate the period, which helps with these hormonal fluctuations and symptom fluctuations. Vagal nerve stimulation, which has some data behind it and actually calms the heart rate and seems to help in a select group of patients. Many of my patients have benefited from getting a device that stimulates the vagal nerve. And then also limbic retraining, which is newer to me, but not so new, I think. And there's just a study that has come out in January of 2024 looking at this Gupta program, which is a limbic retraining program, and actually showing through surveys that there was a substantial improvement in symptoms in many of the disorders that cross this chronic illness spectrum. So I do offer this regularly, as it is something that is not a medicine, which I think is helpful.
Alexis, I'm going to interrupt you right there because
Yeah.
I want to make sure we have time for questions. And this has been
Absolutely.
phenomenal. Are you okay with transitioning to questions? Because we have a lot of questions to cover and we may
Yes.
even run 5 minutes over if everyone's okay doing that. But thank
Absolutely.
you
I'll
for
leave this up. This is the non-pharmacologic treatment of mast cell, and I have a couple more slides, but we can absolutely do questions.
Yeah, I mean, thank you for this phenomenal overview and thank you for this work that you're doing, which has helped so many patients that we share. And I think has really helped this group to understand this newly described condition that does, there's always a healthy dose of skepticism among the medical community when there's a newly described condition that doesn't have like a single diagnostic test. So I think this has been incredibly illuminating. First question is from Meredith Greer. Thank you for an outstanding talk. For those of us that want to initiate workup on our own, what do you recommend? And also her question is, do you have an order set created in Epic? But also, how do we how do we evaluate these patients? I think about like when IBS was first described and how, no, not every IBS patient needs a colonoscopy to make that diagnosis. But it does seem like you're going through a decent number of kind of potentially costly or invasive studies to get to these diagnoses. So can you help us with a list of things that you'd like for us to initiate the workup on our own with?
Yeah, so it's true. There are a lot of different things I'm looking at, I guess, and part of what helps me be successful with these patients is actually finding abnormal things. Like they're very used to having lots of studies done without any abnormal findings, and so it's very validating when things actually start coming back not normal. I start from a POT standpoint. I do orthostatics in the office, and then I also ask them if the orthostatics are not positive in the office to do an orthostatics on their own at home, and we have a handout that we give patients, courtesy of Tiffany Walker, who's using this also in the long COVID clinic. But that helps them do it on their own, and they can do it first thing in the morning when maybe they're more likely to have, sort of a heart rate fluctuation. But I also look at Apple Watches and other data to sort of come up with a diagnosis of POTS. But as far as mast cell activation syndrome and venous disease is concerned, I do have an order set. It's a little it's not polished. I need to work on polishing it up, but it is there in Epic. You can follow me and take a look at what I do. But for the most part, I'm checking those mast cell markers, the ones that we have in the Emory lab. The histamine is very unreliable, but I do it anyway, just in case it comes back high. If it comes back low, I ignore it because it's probably just sat in the lab for 5 days before it was run. And then I look at ultrasounds of the lower extremity veins, and I use a protocol that is the venous insufficiency protocol, not the DVT protocol. And then I do an ultrasound of the pelvic veins. What I didn't comment on in this talk was that ultrasound of the pelvic veins is really inaccurate and unreliable. So when the pelvic vein ultrasound is normal, it doesn't mean that they don't have pelvic venous disease. It just means it wasn't found on that study. And that's when I start looking at more detailed studies like an MRV, for instance. I don't do the
Practically
more
speaking,
invasive
for the
stuff.
lower extremity ultrasound, when you're saying it's not a DVT protocol, is that, I mean, I've never ordered that before. Is that like a click box in Epic that you don't want the DVT protocol, you want the venous insufficiency
I
protocol?
think if you type in venous insufficiency, it comes up.
Okay.
I haven't done it for such a long time because it's just in my favorites, so I can't give you specific directions. But I think if you type in venous insufficiency, it probably comes up. But yes, you're specifically looking not for a DVT study. And if you look at type in venous Doppler or lower extremity venous Doppler, I think a couple things will come up
Yeah.
if you hit that database
And for
instead
those who
of.
are following along, Meredith has dropped that order into the chat so people can copy and paste that. Thank you.
Thank you. I
Yeah,
appreciate that.
yeah, that's great.
Um, yeah, but
Maybe
yeah,
time for one more question, if you
absolutely.
can. I think there's a lot of curiosity about, so thank you for all the questions in the chat. A lot of curiosity about like how long COVID, the incidence of POTS after the pandemic. What is the hypothesized relationship there, if any? Do you have any comments on that, pathophysiology?
Yeah, I think that it's pretty clear that the COVID virus aggravates mast cells and makes them sort of more dysfunctional or heightened or sort of sensitive. I have a lot of long COVID patients that I've seen that I've just started on basic H1, H2 blockers, and they come back and they tell me their symptoms have all resolved and they feel much better, right? So I think that that's a component. I also think that there's underlying venous pathology in these patients, and it gets worse during that hyperinflammatory state during the COVID infection. And that is combined with sort of this microclotting phenomenon, which I didn't go into, but exists in this population of patients as well. So it's a combination of things. And they're difficult to treat. But what I will say is that the patients that see me with long COVID usually had, even if they say they didn't have any predisposing conditions or they felt fine before they got COVID, usually there was some history there of hypermobility, allergy, or migraine. Usually there's, heavy menstrual periods, pelvic pain. There's something there that sort of tips you off. ADHD is a big one, that, patients previously diagnosed with ADHD probably are more likely to have long COVID. So there's a lot of, there are a lot of clues that these are things people just live with and don't really feel are pathologic until they have a major hit to their inflammatory system. So I think it's obviously multifactorial.
This is phenomenal. So I think sadly we have to adjourn there. I know that we could pepper you with questions and how we can manage our patients better for hours after this. But I also think it's extraordinary that we are 1:05 past the hour, and up until like 2 seconds ago had over 95 continued participants. So you have held our attention well. Kim, if you wouldn't mind not adjourning the meeting right away so that Alexis can review some of the really nice comments in the chat box about how well you care for our patients. Alexis, any other recommendations for referrals, if you have any? I know I know your access is limited, but
my access is very limited. Tiffany Walker and Alex Trong see a lot of the patients with long COVID, and they're developing more resources for the long COVID clinic through the Recover study. And I highly recommend them. They have 2 new nurse practitioners that are helping them out. And so I think they're going to have some more bandwidth. My bandwidth, unfortunately, is limited, but if you send me a message or an email, if you have a patient that you have a question about or you want to discuss, I'm more than happy to give treatment recommendations and or potentially see the patient if it seems like that's something that would be helpful.
Fantastic. Alexis, thank you so much for a fantastic talk. And thank you everyone for joining us today.
Thank you so much for having me.